Good afternoon and welcome to the Pulmonary Hypertension Association's preview of the PHA-accredited Pulmonary Hypertension Care Centers initiative. My name is Olivia Onyador, and I am the PH Care Centers Program Manager at the Pulmonary Hypertension Association. The PH Care Centers program is still a work in progress, but enough chatter, excitement, and uncertainty within the PH community prompts us to inform you of our progress and forecast the future. The presentation will be followed by a question and answer period. During the call, all lines will be muted. If you have a question, please feel free to submit it using the chat function on the web interface. You will also have the opportunity to ask questions aloud by using the raise hand function on the web interface later in the call. As a reminder, today's webinar requires a web login as well as the audio call-in. If you are not yet logged in to the web portion, please go to readytalk.com and type in 565-3004 under Join a Meeting. Also, please note that today's call is being recorded. The Pulmonary Hypertension Association has built a very unique partnership between patients, family members, caregivers, and the medical community. Advised by the Scientific Leadership Council, the mission of PHA is to find ways to prevent and cure pulmonary hypertension and to provide hope for the pulmonary hypertension community through support, education, research, advocacy, and awareness. With that, it is my pleasure to introduce the presenters of today's webinar. Dr. Murali Chakinala is an Associate Professor in the Division of Pulmonary and Critical Care Medicine and Director of the PH Clinic at Washington University in St. Louis. He serves as a member of the PHA Scientific Leadership Council and is Chair of the PH Care Centers Committee. Dr. Erika Berman Rosenzweig is an Associate Professor of Pediatrics and Medicine and the Director of the Pulmonary Hypertension Center at Columbia University Medical Center. She serves as the 2014 Chair-elect of the PHA Scientific Leadership Council and is Chair of the PH Care Centers Review Committee. Melissa Wilson is an Advanced Registered Nurse Practitioner, a board-certified acute care nurse practitioner, and the Pulmonary Hypertension Coordinator at Orlando Health Heart Institute. She serves as a member of the PH Care Centers Oversight Committee and is Chair-elect of the PH Professional Network. Diane Ramirez is a dedicated PH patient advocate and serves as the Advocacy Chair for the Piedmont, North Carolina Support Group. She is also a member of the PHA Board of Trustees and the PH Care Centers Oversight Committee. Without further ado, allow me to introduce our first presenter. Welcome, Dr. Chakinala, and thank you for joining us this afternoon.
Thank you, Olivia. First, I'd like to welcome everybody who's taken time out of their busy day to join us for what we think is a really important topic, and that is to introduce our patients and their caregivers and families to the concept in the program known as the PHA-accredited Pulmonary Hypertension Care Centers, or what we like to abbreviate by calling PHCC. And over the next 30 to 40 minutes, you'll be introduced to different aspects of the PHCC program and how it evolved and where it's moving forward. And I think before we, really delve too deeply, we should make sure that we're starting off at the same place in our understanding. And I think that has to start with understanding what accreditation means. It's a big word, and if you go to the dictionary, of course, it comes off the root word of accredit. And accredit means to consider or recognize someone or something as outstanding. That's a very generic definition. When we talk about medicine, we can hone it into a more specific definition, and it's to recognize or vouch for someone or something as conforming with a standard. And probably even more to the point of what we're trying to do, accredit means to recognize, again, someone or something as maintaining standards that qualify the graduates, and by graduates we're talking about centers now, to higher or more specialized professional practice. And accreditation permeates throughout medicine. We see this in a lot of areas. For instance, individual healthcare professionals, whether it's a doctor or a nurse practitioner or a registered nurse, has to go through essentially their own individual accreditation, and most often it's called board certification. For example, I am a board certified lung specialist. Hospitals go through accreditation as well, and this is a really big deal in that hospitals need this accreditation for many other functions to take place. And the main body that accredits hospitals in our country is called the Joint Commission on Accreditation of Healthcare, or abbreviated as JCAHO. And we'll come back to JCAHO here in just a couple minutes. Training programs, in other words, the programs that take our young medical school graduates and transition them to be independent doctors, those residency programs have their own review committees, and that's their form of accreditation. And then more pertinent to what we're talking about today, there are accreditation programs in disease-specific areas. And on this slide, you can see some of the ones that are listed, including rare diseases like cystic fibrosis and HHT, which is a genetic blood vessel disorder. There's also certification programs or accreditation programs for certain types of surgery like bariatric surgery. And these are the surgeries that people get to reduce their stomach size or take out their stomach to help lose weight. And then there's JCAHO, as I mentioned to you a few minutes ago. In addition to accrediting hospitals, JCAHO also has disease-specific certification programs. And on this very busy slide, I've listed straight off their website all the different specific disease certification programs that JCAHO administers to. At the top left in red are several programs that are what JCAHO refers to as advanced programs, such as those from chronic kidney disease, comprehensive stroke center, COPD, or lung volume reduction surgery. These are programs that are more complex and really on par with the kind of program we're promoting in pulmonary hypertension. And when you look at the rest of the list, there's a lot of disease certification programs out there, but what you don't see is anything in pulmonary hypertension. So JCAHO, our biggest accreditor in our country in healthcare, does not have a disease certification program to help accredit centers that administer PH care. So I've tried to explain briefly what accreditation means and how it already exists in healthcare and the void that there is in pulmonary hypertension. Now I'm going to hand this over to Melissa to explain why PHA is promoting center accreditation.
Thank you, Dr. Chakinala. So why is PHA promoting center accreditation? What we know about the delivery of PH care is that it has evolved over time. In 1995, there was only one drug available for the treatment of pulmonary arterial hypertension. This therapy is complicated, and only the experts who had experience using this drug managing these patients that required this medication were the ones that managed those patients. As the options for PAH were few, those patients with PAH were quickly referred to the experts for advanced medical therapies and transplant evaluation. This was more like the European model of centralized care. Since this time, there has been an explosion of therapies available for treatment ranging from pills, pumps, and inhalers. So basically, over time, through research and development, we now have therapies that are not as complicated. In today's environment, PAH care is delivered more diffusely. There's various specialists, including cardiologists, pulmonologists, and rheumatologists, working in a variety of environments, providing different levels of care with variable access to resources. Ultimately, this has led to a less standardized model of care that is being provided across the system. While each patient with PAH is unique and treatment is tailored to each patient type, correct diagnosis is key. Despite strides that have been made over the years, many patients are still delayed in getting the right diagnosis in a timely manner. When clinicians do not follow diagnostic algorithms, then individuals may be under or overdiagnosed. Delay in diagnosis leads to those with PAH presenting sicker at the time of diagnosis. At times, PAH is overdiagnosed due to incomplete evaluation, misinterpretation of diagnostic data, or being placed in the wrong WHO group classification. Overdiagnosis leads to anxiety, unnecessary costs, and undue stress to patients, just as not initiating the most appropriate PAH therapy at diagnosis does. This has been shown through research. There's been a study called the PH referral study, which showed that 30% of patients were already started on PAH therapy at the time of referral. Some of those patients were eventually classified as non-Group 1 pulmonary arterial hypertension patients. Also, in the current environment, insufficient monitoring of PAH patients also occurs. So in understanding these changes that have occurred over time, the PH Initiative mission statement states, establish a program of accredited centers with expertise in pulmonary hypertension that aspires to improve overall quality of care and long-term outcomes of patients with this life-threatening disease. It is a quality improvement project. The accreditation is a voluntary program. Please understand that all programs will not apply for accreditation. Even if your center is not accredited, it does not mean that you're not getting the appropriate care. If you are comfortable with the care you receive, please keep in mind that this program is voluntary and you do not have to sever your relationship with your current provider. There are two types of centers that will be accredited as Pulmonary Hypertension Care Centers. Because of the current environment in healthcare, resources and services offered by different programs, we have devised a two-tier system. Both offer quality care, early diagnosis, increased research opportunities, and more patient support. There are 5 main categories that the site reviewers will focus on for accreditation: the center director, center coordinator, program staff, and support services, as well as the facility and research. I'll next briefly describe to you that criteria for the comprehensive care center, or you can think of that as Tier 1. The center director must be trained as a pulmonologist, cardiologist, or critical care medicine. They have to have greater than 2 years experience in treating pulmonary hypertension, be involved in pulmonary hypertension education. The Pulmonary Hypertension Care Center coordinator has to be a licensed care professional, so this can be a registered nurse, respiratory therapist, or pharmacist, for example. They need to be knowledgeable about all approved PAH therapy and also be involved in education related to pulmonary hypertension. The program staff and support services need to include a sizable amount of patients that have pulmonary arterial hypertension, must be proficient with all therapies, including parenteral therapies, which are things such as IV or subcutaneous therapies. It involves multiple medical consultants, including cardiac anesthesia and rheumatology. Must have access to a transplant program, but you do not have to be a transplant program. Needs to include a social worker, nutritionist, and have palliative care services as well. The facilities must have specialized inpatient units and ICUs, so wards are being like a step-down unit or a progressive care unit. It has to include a cardiac cath lab, have certified echo lab, pulmonary function labs, and pharmacy has to have access to all advanced therapies. Criteria number 3 are research. The center must actively participate in clinical research, have knowledgeable research staff, and have contributed to medical literature. I will now turn it over to Dr. Erika Rosenzweig.
Thanks, Melissa, and good afternoon, everybody. Now that you've heard a little bit about what accreditation means and why PHA is promoting center accreditation, I'm going to discuss how this accreditation system will actually function and give you a general timeline of when it will roll out. While this has been on the minds of many PH specialists for several years, and a goal of the community, it was really first formally launched in the fall of 2011 with the first PHCC initiatives. At that time, a PHCC committee and 4 task forces were formed, and I'm going to describe those in just a moment. And this committee ultimately reached an agreement upon the PHCC center criteria, constructed PHCC governance structure, and developed a 5-year business plan with determination of accreditation fees. We officially launched the pilot program this past spring in 2014, which is currently ongoing, with the review of the first 6 sites, and are set to formally launch the program this summer. So before I go over the specifics of how the accreditation will occur, I'd like to give you a brief overview of the structure of the PHCC initiatives, committees, and task forces. On this slide, you can see that the PH Centers Committee is led by Dr. Chakinala and is comprised of PH experts and members of the PHA community. The PH Centers Committee has delegated 4 specific task forces with key jobs in this initiative. So on the left, first we have the Criteria Task Force led by Dr. Ranu Dees, and they will really tasked to establish center criteria and process for center certification and recertification. The next task force, Task Force 2, is regarding funding and sustainability, and it's led by Dr. Roham Zamanian. And this was developed to explore independent funding mechanisms for establishing and maintaining the PHCC system. The third task force, which is co-chaired by Joel Worth and Abby Palms, is the Implementation and Credentialing Task Force. And they've been working very hard to develop a rollout scheme for the PHCC system and explore credentialing options. And finally, there's a Patient Registry Task Force led by Dr. Steve Kaywood. And this task force is specifically attempting to develop centralized patient registry for tracking outcomes and facilitating future research opportunities that will emerge from this program. On this slide, we also have an overview of the PHCC governance. And actually, if we start from the bottom and work our way up the chart, we see that there is the PHCC Review Committee, which I sit as the chair, and it's comprised of approximately 20 physicians and allied healthcare professionals in charge of reviewing the applications and making decisions on accreditation. We report up to the Oversight Committee, which is chaired by Dr. Mike Magoon, and this committee is in charge of, if you will, the rules and regulations of the program, and if any conflicts or appeals arise, they will be sent up to the Oversight Committee for review. And of course, both of these committees then report up to the Scientific Leadership Council and ultimately the PHA Board of Trustees. I'm providing you a map here just to give you an idea of the pilot site visit locations. Again, these were the first sites that we have visited this spring to really work out any kinks in the program prior to its official launch. So these were very important, these visits to us, to help us ensure that our plans for launch were appropriate and to make any adjustments to the formal program prior to its official launch this summer. For the pilot program, you should know that sites were chosen to represent both large and medium-sized centers with geographic diversity and various internal models. And we will be completing our last pilot site visits next week on May 9th prior to rolling out the official program. So in this slide, we see a general timeline of how we anticipate the accreditation process to occur. As you can see, after completing the pilot site program, we will begin with the official accreditation of Centers of Comprehensive Care, which we will expect to take in total approximately 2 years for the first cycle to complete. And once we are nearing completion of this first cycle of CCC accreditations, we'll begin to accredit the regional care programs, or RCPs. And the rationale for accrediting the CCCs first is that the RCPs will need to be affiliated with a CCC program. The next few slides will describe the actual accreditation process. So the first step is an online application, which will be submitted by an applicant center. And you can check out the PHCC website for application details. And this will consist of a single online application for all candidate programs. The applications for the CCC programs are going to start to be accepted for the initial round of accreditation, probably in late June of 2014, which is coming up on us. Applications for the CCC pediatric program accreditation will likely be launched in early 2015. And the RCP candidate applications will be processed subsequently starting in 2016. So once an application is submitted, the applications will be reviewed by the review committee, and a site visit date will be set if the application appears to meet criteria for a CCC. The review committee members will be chosen to perform a site visit, and that visit will be comprised of a one-day visit by 2 healthcare professionals, 1 physician and 1 allied healthcare professional. And the point of these visits are to verify the information from the application and to gain a deeper understanding of the program. So that day will be very busy for the reviewers, where they will spend time meeting the center's staff, meeting key institutions' personnel and administrators, inspecting the facilities, and performing a limited chart review. Finally, the application and site visit evaluations will be reviewed by the review committee, and an accreditation decision will be made. If a candidate center wants to appeal an accreditation decision, the Oversight Committee will arbitrate. And this reaccreditation cycle is to occur every 3 years. And on this slide, you have a general look at various cycles. We will be rolling them out as a quarterly system with application cycles and notification cycles for applicants. And it is our expectation that roughly 120 CCC centers will undergo this process in the first 2 to 2.5 years of rolling out. So next, I'm going to turn it over to Diane Ramirez to give a patient's perspective on the PHCC.
Hi, everyone. Thanks for taking time out of your day to participate in this webinar. I'm just going to give you a little bit of a highlight as a patient, what the benefits will be. And as you see here, it says it will increase awareness of expert care and access to expert care, earlier and more appropriate diagnosis. A lot of us have been through problems getting the right diagnosis for pulmonary hypertension, and we've gone back and forth to different doctors and different medicines, and a PH Care Center could avoid that and just help improve that time between symptom onset and your actual diagnosis. A high-quality standard of care, increased education and support for patients and caregivers, and more increased opportunities to participate in clinical research, which is so important to us as patients. That's where a lot of our hope lies, is in the research that's available and how we can participate. And the care centers will all be connected. So everybody will be working on a lot of the same stuff, and treatment's going to be the same. So we'll be able to get more information for ourselves, for our family and friends, and information on research and how we can participate. And this is how it will benefit the medical community. It's going to help promote diagnostic and treatment standards so that it's just, it says on the slide, provide a blueprint for the professionals. And that will help so that when you have someone that's newly diagnosed coming to a center or to a doctor with symptoms, and they're made aware of the care centers, patients are going to be getting the same treatment. You're not going to have a lot of discrepancies as far as, one center doing it this way and another center doing it that way. All of the centers will be linked together so that when an issue comes up, which I'm sure a lot of patients I know have gone through, where your doctor wants to prescribe dual combination therapy and the insurance company says no, and then the appeal process begins. And by having the centers linked together, the doctors have a louder, more singular voice, and it's more uniform, so that kind of thing won't happen as much, we're hoping. The insurance companies will see that there's a bunch of centers that are treating this illness the same way, and they're all doing combined therapy, for instance. So it would help with that kind of stuff. And it will just encourage the centers to work together for that same reason, so that the quality of care is the same across the board for all patients. Again, I do want to repeat what Melissa said earlier. This is a voluntary program. I know there have been patients that have gone ahead and reached out to their doctors to give them information. But if you're happy where you are, you don't have to change. We don't know if all centers are going to apply to be a care center. All of that is still, we're still working out the schedule. But as a patient, for me, it's very exciting. It's something that I've looked forward to for a very long time, to see that we'll all get the treatment that we need in the proper time, and, it's all above board across the nation. And I'll turn it back over to Dr. Chakinala.
Thank you, Diane. So you've heard a lot about the rationale for developing this program and how we've taken a lot of the early steps leading up to this exciting time where we're going to be launching the program. I want to close just by with a few slides to help shine the spotlight on all of you. We're doing this primarily for the patients out there. As others have told you, we feel like there are shortcomings in how PH is cared for in our country at this point, and we want to elevate the level of care throughout the country at the centers or even places that aren't ready to be centers. And clearly the spotlight's on you guys, and so to help you feel more welcome into the process, I want to just spend a few minutes talking about what you can do to help the PHCC. First and foremost is to learn as much about it as you can. And I presume I'm speaking to the choir here because all of you have taken time out of your busy day to learn about this. But we're only scratching the surface here today on this 45-minute presentation. There's plenty more you can learn about the PHCC. You can visit the PHCC website at www.phcarecenters.org, which is a website coming off the main PHA website. And you can see the criteria, which you've only heard part of today, and also understand a little bit more about the governance and the goals of the program. Another great way to learn about the PHCC is to attend conference. There's already many reasons to attend the conference in June in Indianapolis. You can see the dates listed here, but this is just one more thing because we will have sessions and materials, and you'll have a chance to talk to other patients and healthcare professionals about the PHCC. So there's plenty of opportunities to learn more about it. And then once you learn about it, we encourage you to promote the PHCC to others. Please try to educate your peers. I know the value of a great support group. I have a wonderful one affiliated with our center in the St. Louis area, and they truly do a great job of imparting knowledge to each other. And I would encourage that all of you use that forum to inform the masses about the PHCC. I think this is particularly important for the new patients, the ones that still have a lot of questions, may not have a definitive diagnosis, are really lost, if you can remember what many of you went through those first few months or year when this diagnosis came to light. And I think these are the kind of patients that can benefit from knowing that there are centers out there that are not only focused on the care of pulmonary hypertension, but now have gone through this accreditation process and have proven themselves to meet the criteria that the PH community has felt to be important. Diane mentioned earlier about educating healthcare professionals. Well, clearly, this is not going to be knowledge that all doctors and all allied health professionals dealing with PH are going to know a lot about. Some are going to be quite removed, and some are going to know quite a bit about it. So I'd encourage you to, in a very healthy and non-confrontational way, to bring this program up to your healthcare professional, inquire what they think about it. And I want to emphasize again what others have said on the call. We're not here to tell you that your doctor or your program isn't doing a good job taking care of you. They very well may be, and if you're happy, whether they join the voluntary program or not, it shouldn't matter whether you decide to stay with that program or that doctor. It all comes down to your satisfaction. But it's nice to know, though, that there is a program out there that is going around and accrediting PH centers, that they're providing high-quality, comprehensive care. The next slide is the somber reality that a program like this costs a lot of money. And this is something that we've discussed at great length. It's projected that our annual costs for the PHA to run this program is going to be anywhere between $400,000 and $500,000, and this is going to be to conduct the site visits, to maintain materials, including websites, to pay for PAH personnel who are going to be dedicated to servicing and maintaining the program. In addition, we have grand desires to have a national patient registry, and this is really critical for the PHCC to accomplish its missions, which is to be a quality improvement project and to help elevate the care around the country. You have to be able to track outcomes and institute policy changes that might influence those outcomes. And it's very difficult to do that across the country with potentially 150 or more programs if you don't have some type of tool to collect and track data. And to construct a registry like this, our registry task force is estimating that over the first 5 years alone, it'll cost about $350,000. So you can see that this is a tremendous expenditures that this is going to generate for the PHA. But the PHA has many other missions and desires, including conducting conferences and medical education and advocacy. So we can't expect the PHA to foot the bill for this, or otherwise it'll monopolize all their resources. So as a result, we've really talked a lot and looked into avenues of fundraising and developing a sustainability model. And we've come around to now to the plan that long-term PHCC expenditures will be offset by the accreditation fees that applicants and centers will pay. So all these programs that are going through the accreditation process, and then once they are accredited, will pay upfront and then annual fees, and in essence they're contributing to the pot, which will then help the whole program run. But in spite of these fees, there will still be deficits, and there's still the registry to fund. And in particular, the first couple of years until we get all the programs accredited, there will be significant deficits. So we've had to explore many avenues of fundraising, and I'm pleased to say that we've had such tremendous grassroots support from various members in the PH community that we've already been able to raise some funds through some very generous individual donors. We've also explored some healthcare foundations and have received some positive news and receptions, and we're hoping to reap the rewards from some of these applications soon. I want to stress, though, that the one source that we have not gone for resources to fund the PHCC is our friends in the pharmaceutical industry. And that is a very delicate relationship. We've had tremendous success from the pharmaceutical industry in providing these FDA-approved therapies, which now number 12, that have saved lives. And we want to keep that going. We want them to stay engaged in the PH community and continue to do research and bring more drugs to market. But at the same time, we felt this program, the goals that it embodies and the spirit by which it came out of, needs to stay removed from the pharmaceutical industry so that we can function in an impartial and an unbiased way. And this philosophy has been uniformly supported by everybody in the PH community, all the doctors listed on the committees and task forces, and I'm glad to say we have upheld that principle even to today. So how can you help in terms of raising funds for us? Well, there's many ways. If you're in a position that you're able to, providing donations to the PHA earmarked for the PHCC is a great way, and any size donation would be welcome. And if you are somebody who works for an employer, especially a large company, you might want to take advantage of employer matching programs, where you can sometimes double the donation and make a bigger splash. You can also fundraise, and this is a great way. It can be a lot of fun, too, and something maybe your support group can help organize. And these funds can be raised to help the program nationally, or it could even be a partnership with the local center as they're trying to raise the funds to meet the accreditation fees. So it'll really vary on your individual situation. The important thing is if you're able to consider a fundraiser to help raise money for the PHA, for the PHCC. You can also let us know about foundations in your area, maybe either through your employer, through your church, or a national organization, some places that are interested in funding exciting programs like this, and we have terrific PHA staff who can take that information and then explore the viability of that specific opportunity for the PHCC. If you would like to make a donation, there's a website address on this slide, phassociation.org/donate, and please just put in the comments field that you'd like your donation earmarked to the PHCC. So with that, I want to close. Again, I want to thank you for your attention, and we promise to leave a significant amount of time for your questions and comments, and I and the rest of the speakers are, I'm sure, very excited to hear what you have to say. Thank you.
Thank you all for that very informative presentation. Now we will begin the Q&A portion of today's webinar. I'd like to note that we can only answer general questions, so we kindly ask for you to avoid asking questions specific to your PH treatment center or care team. Thank you in advance for your consideration and cooperation. If you have a question, feel free to submit it using the chat function on the web interface. You also have the opportunity to ask questions aloud using the raise hand function on the web interface. When I call on you, please press *7 on your phone at that time to unmute your line, and press *6 to remute your line after you have asked your question. We will attempt to answer as many questions as possible. The next question is, when are the centers going to start being accredited?
I can try to answer that. As Erika had mentioned, the pilot program is about 2/3 of the way through in terms of conducting the visits, and then we'll have the important job of sort of analyzing the data from those 6 visits and updating and modifying anything, including the actual criteria or the method by which we're evaluating a center as meeting the criteria. We don't anticipate that there will be substantial changes, but it'll still be a process that will take some time. And then there's we have to go through the steps of educating all of our colleagues who haven't been working on the PHCC these last couple of years on how the process will work, and give them time to start collecting their specific center's data and making arrangements for payment of accreditation fees and everything. So the end result of all of that is that we anticipate that applications will be open for receipt around the time of the international conference in June, and that we will then start actually receiving the applications over the summer and start conducting site visits for real towards the later half of the summer.
Thank you. Our next question is, this is very exciting. I would like to share it with my support group, and how do I do that?
Olivia, maybe you could explain to the folks what's going to happen with this recording today and how people might be able to access it if they weren't on the call.
Okay, so after the recording today, within the next few weeks, we will be posting this recording. So you will be able to access this recording. Earlier, we do speak about how you're able to share this information with others or the PH Care Centers that you attend. You can go online to www.phsassociation.org and go through the medical or the patient tabs and access PH Care Centers. Or you can go to www.phcarecenters.org and you can find all the information about the care centers on the website. So our next question is, will non-PH centers be able to ask PH Care Centers for review of patient records, or will patients need to travel to a center?
I can jump in there. The patients, again, this is a voluntary program, as was highlighted earlier, so our hope is ultimately, once there are comprehensive care centers of care, and there'll be regional centers as well, that they will encourage these affiliations or relationships between these bigger programs and even the smaller regional programs. So with respect to a patient's record, that is always up to the patient to request and have access to that if they want to share it between 2 centers. So there won't be an automatic way for sharing of that personal private information. But again, the program will start to encourage these relationships between the smaller programs and the centers so that there's more communication if you're being followed by 2 centers.
Thank you. So our next question is, what are the fees and criteria for a new center to apply?
I can try to address that one. So I think the criteria, you heard a lot of it today on the presentation, but essentially there's 5 categories, again, that Melissa walked us through, a program must have a center director, they must have a center coordinator, they must have the appropriate support staff, and then the facilities have to be in place for complete evaluation and management of PH patients. And then for the CCCs, or the top-tier centers, if you will, there has to be a strong commitment to doing clinical research. Now, for the regional clinical programs, all of those same categories except for the clinical research component are also required, but there are some subtle differences even within those five different categories for the two different tiers, and primarily the bar is a little higher in terms of the rigor by which criteria have to be met for the center director and center coordinator and the facilities if you're at a CCC versus RCP. If you want a more detailed itemization of the criteria, I would steer you towards the PHCC website that was mentioned earlier that you can find on the main PHA website to learn more. And then in terms of the fees, that's still something that's being finalized within the structures of the pulmonary hypertension community. We plan to go public with that information later, or next month, excuse me. But in general terms, there will be some upfront fees that a new applicant will have to submit in order to offset the costs and the time for PHA staff and the review committee to conduct the site visit, and everything that has to be done to determine whether they're in a credible site. And then there will be annual fees, a much smaller amount, that will have to be paid by the sites. And then every 3 years they'll go through a reaccreditation process where, again, there's a bigger fee just to offset the costs of conducting the reaccreditation visit. So that's as much as I can divulge at this time, but thank you for your question.
Thank you. Our next question is, why are pediatric centers not in the first wave of accreditation? Will there be different criteria?
So I can take that, also chair of the pediatric task force. So you should know that those criteria are slightly different, but follow the same general theme of the adult accreditation program, and they've been developed and are being finalized. And we envision this to be a much smaller, at least by numbers, endeavor than the adult accreditation process, where there are far fewer pediatric programs in the United States. And so the adult programs were launched first. Doesn't mean the pediatric programs aren't just as important, but they're probably going to be up and running and ready to go with those approximately 6 months after launching the adult programs initiative. So they are coming soon down the pike, and again, the criteria, the ones that are specific to children and children's needs, were tweaked a little bit, but we'll follow the same general theme for the adult accreditation programs.
Thank you. Our next question is, insurance companies are key to allowing patients to access care at specialized centers. Have we at PHA done anything on this end to educate the insurance industry about PHCCs?
I can try to address that one, and that's a very complicated question, and we could probably spend an entire afternoon talking about it. I think it's a very astute question, and something we have talked about from the very beginning is just the reaction and reception that insurance companies may have for a program like this. And I would preface it by saying that at least in PHA leadership's mind, part of why we even went down this pathway is because of some feedback we received from some insurance companies and payers that they're sort of getting lost with all the treatments out there and what should be approved and who should be eligible to prescribe these things. So there was a lot of chatter going on, and in fact I can recall one specific medical director of a large insurance company in on the Atlantic coast urging PHA to consider organizing this very kind of program. Now, I can't tell you, though, that all insurance companies view the PHCC that way. What we've done so far is that we have been engaging some medical directors from a few of the larger insurance companies around the country. There is a survey that was created that's being conducted on a one-on-one basis with medical directors where they hear a little bit about the PHCC, and we ask some targeted questions about the value of this and their perceived advantages and disadvantages about the program. And it's really difficult for us to say much more at that point as we're just starting to collect that data and then how we turn that information into a positive for us. But the person in the audience who asked this question hit on a very key point, and that is educating the insurance industry about the PHCCs. Our goal is to accomplish that through many means over the next couple of years. And the harder part, though, is to know how that's going to impact their actions. I think it's safe to say, though, that insurance companies are very much driven by outcomes and the evidence to support what we think the PHCC will do. So it's very important, it's incumbent upon us as we roll this out, we really try to keep track of some of these key things like, how long people are surviving. Are we helping reduce complications and hospitalizations, just to name a few things. And if we can show this program is accomplishing those kind of things, then it's going to be much more widely adopted by insurance companies. Thank you for that really important question.
Thank you. Our next question is, have patients been involved in forming the PHCC program?
Sorry, I hate to monopolize all the answers here. I would just say simply because I've been, out of the four of us, involved in this the longest, I have some more insights into this than Erika, Melissa, or Diane. And I'll just quickly say that, yes, very early on in the process, when we first developed the concept and developed the criteria, we convened a panel of patients and caregivers from around the country. It was about, if I recall, 5 or 6 very knowledgeable, active members of the PH community. Some of them were patients, some of them were parents, some of them were caregivers, support group leaders. They had multiple hats that they worn for the PHA. And they reviewed our criteria and actually made some wonderful suggestions and things that we ultimately added or enhanced the program with. One very tangible example I can give you is that the palliative care programs were something that the panel thought is really important and something that's been an under-recognized need in the pulmonary hypertension world. And so we added that as an attractive criteria for a program to have, a palliative care service. And so that's just one example. But overall, the patient panel was extremely supportive and really felt that this will be a tremendous leap forward for the PH community. And I realize it's a small sample size, but us coming out and hosting this webinar and posting this on our website and then talking about this at the PHA conference will allow the masses to hear more about the program. And we welcome your feedback, and there is a way to send us your feedback on the website as well, too, if you were to check out the PHCC website. Thank you.
Thank you. Our next question is, who is serving on the review committee?
I can take that. So again, the review committee is composed of, I sit as the chair, but there are 20 physicians, 10 physicians, 10 allied healthcare professionals, and we actually have 2 alternates. And it's a fairly large committee, but this is a large effort, and we're going to need, and have already been training each and every one of them to be able to have the tools to go out to the sites and meet and review and bring back to the entire panel the information that we're going to need to review an application. So I don't recall if the list is actually posted anywhere on the PHA website, but I'm not going to, for the sake of time, go through each member, but I can tell you again, it represents a diverse group of people from various geographic regions, backgrounds, specialties, and with a whole wealth of experience.
Thank you. Just as a reference, the review committee members are posted on the PH Care Center's website if you would like to go look at that. So our next question is, will the PHA registry be in addition to the registry being developed by the Pediatric PH Network, or will this duplicate some of those efforts?
I'm going to take that one as well. This will be a separate registry, and I think because it's in development, there's always the opportunity to decide how data could or may not be shared, or for programs, how we can make an opportunity out of already existing databases. So again, it's currently in development, and I think we'll have to see how that unfolds in the future, but certainly we hope that there will be an open dialogue to not to make things more difficult for people, but to really use this as an opportunity to learn from our databases.
Thank you. Our next question is, having a coordinator is a great idea, but what if a center has a doctor but no coordinator? Does that mean they can't be a PHCC?
I can try to address that. So we want to be sensitive, and I'm going to try to answer this from a larger perspective. We've tried to develop the criteria with a lot of flexibility to give Erika's committee the opportunity to really give everyone a fair chance, because we realize that centers have been practicing already for 10, in some cases 20 years, and have adapted to their environment. While we'd certainly want to see some uniformity in how centers are functioning and thus, equalize the care across the country, if you will, we are sensitive to the fact that there are going to be some unique situations that call for the committee to be flexible with their evaluation. And again, that applies really to all the criteria. But at the same time, we do feel like that there are some real central tenets to the criteria that we really do want to, we really do feel like are necessary to be in place. The two probably most prominent things is that you have a knowledgeable and committed center director and a center coordinator. But even there is language in the criteria to allow centers some flexibility on how that coordinator position is filled. It could be a lot of different, it could be somebody from a variety of backgrounds. It could be a respiratory therapist, a nurse practitioner, a nurse, a pharmacist perhaps, and it could be a position that's shared even by multiple people, so that maybe there's not one dedicated full-time 100% coordinator, but if there's a couple of people that each spend 50% of their time dedicated to the PH Center, that coordinator role or that criteria can still be checked off. So without seeing more specific information about a hypothetical center, it is difficult to answer that question, but we are trying again to build in enough flexibility to allow the centers that really are providing good care and are committed to this to have a fair chance at being accredited.
Thank you so much. I think this is going to be our last question. The question is, what is the definition of regional in regional CCCs?
Regional care programs are, if you look through the criteria, it's not because it has to be in a certain region, but usually it's, again, in affiliation with a larger center, probably within that designated region. So you wouldn't have a center in Philadelphia linked to a center in Texas. But so that's where that came from. But it is expected that perhaps the regional care program might not have all the features of a CCC, but still, almost alluding to the previous question, have many components of a program with close ties to a larger center, let's say, that they can refer a patient to who needs escalation of care or transplantation or some other advanced care. So, again, these criteria will be laid out in terms of the inherent differences between the RCP and the CCC.
Thank you. So our time has ended, but I would like to thank Diane Ramirez, Melissa Wilson, Dr. Rosenzweig, and Dr. Chakinala for joining us today and leading our conversation. A recording of this webinar will be posted on PHA Online University in the coming weeks. I would also like to mention that PHA will be visiting the Food and Drug Administration from 1 to 5 p.m. on Tuesday, May 13th, to speak with drug reviewers about living with PAH and the effects of current treatment on daily living. If you would like to attend, registration is due today and can be accessed at www.phassociation.org/FDA registration. For those who may want to ride with PHA to the FDA, please sign up at www.phassociation.org/FDA bus. As always, feedback is appreciated, and you can email any questions, comments, or concerns to the PH Care Centers program at the email address medical@phassociation.org. Thank you very much for attending this webinar, and have a wonderful afternoon.